Yeah, good evening, everyone, to this Wizard Ophthalmic Society's late night webinars initiative by VOS new team led by Dr. Shirish Thoras sir, Dr. Shriram Lavode, Dr. Durgesh Cholia, and Chairman Scientific Committee, Dr. Shamik Mokadam. So we have today our esteemed speakers joined with us, Dr. Manoj Chandra Mathur, he is AIS Treasurer from Hyderabad, Dr. Kuresh Maskati sir, past President of AIS is with us, and Dr. Jay Bhupi from Pusat is with us. We have got our chairpersons, Dr. Shriram Karandikar sir and Dr. Satish Kothare sir. They have joined us. I'll be the moderator for this MedicoLegal update, and our panelists, Dr. Vinod Atlakya sir, Dr. Nitin Upadhyay sir, Dr. Abhijit Patil, Dr. Vidya Dashputra madam, Dr. Jayant Aade sir, Dr. Ajay Khandewale, and Dr. Abhijit Patil. They have all joined. So now over to our President of VOS, Dr. Shirish Thoras sir, for his welcome address.
Thank you, Viral sir. Good evening, esteemed speakers, chairpersons, panelists, and friends. It's a great pleasure to welcome you all to this significant medico-legal webinar. Friends, it's a brainchild of our scientific committee chairman, Dr. Shamik sir, to have a Beyond the Book series of the webinar. As you know, these things are not much taught or discussed in our PG curriculum, but they are very important in our day-to-day practice. So we wanted to have it included in our scientific sessions and webinars. I'm sure the discussion and insights shared will help us in day-to-day practice. Friends, we are honored to have an impressive lineup of our speaker, respected Dr. Kuresh Maskati sir, Dr. Mathur sir, and Dr. Bhopi sir, who are experts in their respective fields. Dr. Karandikar sir and Kothare sir as a chairperson. I'm sure that their invaluable tips will clear most of our doubts regarding medical legal issues. Friends, my sincere thanks to Dr. Viral sir, who worked very hard to get this CMA done. So, without much ado, I will request Dr. Shamik sir to have a few words about this CMA. Over to Shamik sir.
Thank you very much, Shirish sir. As spoken about the late night webinars that we are going to have, it is going to be a series. We'll conduct it across the year. This being the very first webinar with Dr. Kuresh Maskati sir, Dr. Mathur sir, and Dr. Jaibupi sir as our speakers. Without much of delaying the
will clear
time
most of
and
our
taking
doubts.
time from all of us, I'll continue with inviting Dr. Viral sir to moderate the session and go ahead with the webinar. Thank you.
So now I invite our chairpersons, Dr. Karandikar sir and Dr. Kothare sir, to take over the proceedings further. Karandikar sir and Kothare sir, please go ahead, sir.
Good evening, everybody. At the outset, let me thank the organizers, Shirish, Shriram, Shamik, Durgesh. All these members have got their mythological names, in fact. So I am glad to chair this very first session of our new VOS team. The topic is very important. Actually, in these summer days, this cannot be called as a late night webinar. It's all right to have a such webinar and of very great importance, which can give you sleepless nights sometimes. So the first speaker, as decided earlier, is Dr. Jai Bhopi. Jai Bhopi had his post-graduation from Medical College Nagpur, that is Indira Gandhi Medical College. Then he did his fellowship at Shankar Netralaya, Chennai, had a consultant's post at Ganpati Rugnalaya, Jalna, and despite his academic interest, he opted to practice at a remote place, at a town place like Pusat in Yatmal district. That is really creditable on his part. What is more important is that he never left behind his academic pursuits, and he authored a book, what is called as Evidence-Based Approach to Cataract Surgery. It is very difficult to pursue our academic interests from remote places or town places. Nowadays, to some extent, because of technological advances, it is possible. But without wasting further time, I call him to have a talk on medical record keeping for ophthalmologists. Jai Bhopi sir, please.
Jaisal, you can start sharing your screen.
Yeah, we can see the slides.
So good evening, everybody. First of all, I would like to thank the Vidarbha Ophthalmic Society President, Dr. Shirish Thorat, Dr. Shamik Mukadam, Dr. Viral Shah for giving me this opportunity. Today, I would be speaking on medical records keeping for ophthalmologists. So as we all know, proper documentation of medical records of each and every patient coming to our clinic is need of the hour. Whatever you ask the patient, observe clinically, analyze scientifically, explain to the patient about his ailment, and operate right in black and white. So regarding the importance of record keeping, first of all, we can evaluate our own results, our operation results, then our data for scientific paper presentation in conferences is easily available. We can analyze the data for paper publishing in peer-reviewed journals. And last but very important, it is helpful if any medical litigation is there. The most important use of record keeping is when issue of medical litigation arise. Because the legal system relies mainly on documentary evidence in situation of alleged medical negligence. There is a dictum, poor record means poor defense and no record means no defense. Then coming to methods of record keeping, first is manual method. There are certain limitations for this method. There is large storage area is required and we have difficulty in retrieving the records. The most preferred method is electronic medical records. That is neat and tidy. Data can be easily stored and retrieved. Description can be fully typed, so no errors in understanding handwriting. Previous data of patient is easily available. Fundus photo, OCT, perimetry images are all available at one click away. So coming to medical records, one by one we will consider regarding the history records, clinical examination records, diagnostic test records, pre-operative care records, operation notes, and post-operative care records. We will consider one by one. Then history records. We will see how documenting history is important. It can save us if patient goes in consumer forum. This is the first case in which cataract surgery was done, which was uneventful. There was non-improvement of vision. Patient approached consumer forum, but still the result came in favor of the doctor because in history notes it was clearly mentioned the decreased vision in that eye was since childhood and the eye was amblyopic. This shows how simply documenting the history is very important for us. Then coming to documentation of the clinical findings. This is another case in which cataract surgery was performed, which was uneventful. There was recurrent post-operative inflammation and iritis in that patient. With all possible treatment, I ultimately went into phthisis. Patient approached consumer forum. But the result was still in favor of the surgeon. Only because preoperative documents clearly mentioned that case was a case of complicated cataract with signs of healed uveitis and cataract was operated under steroid cover and under guarded visual prognosis. This shows, friends, how documentation of clinical findings always come to our rescue if there is any medical litigation. Then coming to documentation of investigations. This is another case in which cataract surgery was performed in diabetic patient. There was non-improvement of vision. Patient approached consumer forum. Result came still in favor of the surgeon, only because preoperative OCT finding came to his rescue, showing significant preoperative macular edema, and patient had received anti-VEGF along with cataract surgery. So this is a classical case of documenting evidence of investigations done before cataract surgery. Then coming to preoperative care, this is another case in which cataract surgery was performed, uneventful. Patient had end of early post-op period. Patient was given intravitreal antibiotic injections, referred to VR surgeon, and there he underwent vitrectomy. Because of this, case was filed in consumer forum for compensation for non-improvement of vision and all the mental and physical trauma happened to the patient. The surgeon still escaped clean because of preoperative notes mentioned. The preoperative notes were fumigation and autoclaving of instruments properly done and documented. Betadine eye drops were put and mentioned in the case paper. Preoperative antibiotic drops were instilled and mentioned. And patient was referred to VR surgeon. Date, time was mentioned in the case paper. So, friends, this is proper documentation of preoperative notes, how it saved the doctor. This shows. This is another case. Operation notes, regarding operation notes. Cataract surgery was performed. There was compromised vision and case was filed. But still, the result was in favor of surgeon. Because that case papers showed case of posterior polar cataract. Operative note showed rent occurred and anterior vitrectomy with IOL implantation in the sulcus was done. Preoperative notes mentioned cataract surgery was advised, anterior vitrectomy may be needed. So premium IOL could not be put. As we all know, PC rent is bound to occur in posterior polar cataract and it happened. Good part is everything was documented. Detailed OT notes made the consumer forum result on the surgeon side. Then coming to OPD prescription, this is very important document. When we see the patient while prescribing the drugs, name of the patient is important, date and treatment preferably in capital letters. Duration of eye drops should be mentioned. Signature of the doctor is a must. And review for follow-up date is also necessary. Date is very important as undated prescription, OPD prescription can land a doctor in trouble if patient misuses it. This is the case in which patient had giant papillary conjunctivitis. Steroid eye drops were prescribed for limited period. Patient used steroid eye drops for long time. Patient developed steroid-induced cataract. So patients used the doctor. Doctor still got out clean because his prescription clearly mentioned steroid eye drops to be instilled for particular period and tapered off gradually. And there was a tip mentioned below on OPD paper, long-term use of steroid eye drops can cause cataract and or glaucoma. So then coming to the informed consent, this is very important document. As we operate daily, the informed consent should be procedure specific. That is whatever we are operating, like only cataract we are doing, cataract with IOL or cataract along with pterygium, cataract along with anti-VEGF injection, cataract along with vitrectomy, that we have to mention. It should be procedure specific. Risk involved in the cataract, in the surgery should be mentioned in that consent. Separate consent should be taken for surgery and anesthesia if it is done under GA. And primary surgeon's name should be must and should be signed. Then another important document is discharge summary. After operation, we discharge the patient. You have to give the discharge summary. In that, date of admission, date of discharge, date of surgery, surgical procedure, treatment advice, precautions to be taken post-operatively, and date of next follow-up should be mentioned clearly. And it should be signed by the consultant. One copy should be kept with the surgeon. Discrepancies in discharge summary and hospital records can raise suspicion about tampering of medical records, and this should be avoided. Then another important document is referral letter. If we feel that the patient cannot be handled by us properly, we refer the patient. This is another important document. That referral letter should include date, time of issue, patient's condition, cause of referral, and one duplicate copy should be kept with patient signature. Then another document is medical certificate, which is very, very important document. Most of the time patient asks for medical certificates. Just maintain register of medical certificates issued by us with at least one identification mark of the patient and patient signature on it. Lot of cases of patient misusing medical certificate has been seen due to lack of date on it, time, and issued backdated. It can create problems. There are certain NMC guidelines of record keeping. Patient can approach consumer forum within 3 years if he underwent operation or if he has taken treatment from him. So we have to maintain outdoor and indoor records for at least 3 years. If patient demands for some reason his case papers, we have to give it within 72 hours. These are the NMC guidelines. Similarly, in pediatric cases, if the congenital cataract is performed, a medical negligence case can be filed by the child after acquiring the age of majority. So it is mandatory to keep such records for at least 18 years till the child gets adult. In medico-legal cases, documents to be kept preserved with us until the case is solved. To summarize, medical records is an important aspect in one's medical practice. It can only help to improve our patient management, develop our treatment plan, improve our personality by presenting and publishing studies, but also helpful if legal problem arises and sued in consumer forum. Thank you.
Thank you. Thank you, Dr. Jai Bhopi. You have nicely described the importance of documentation. It cannot be overemphasized than whatever you have said. We will have questions in the last, after we finish up with all our lectures. The next speaker is Dr. Quresh Muscati. As you all know, Muscatis are... Can you hear me? Are you in a position to hear me?
Yes, sir. We are hearing you clearly.
Yes, sir.
Yes. Muscatis are well known to all Indian ophthalmologists. Senior Muscati was known to the people of my age group, while Quresh is well known to all the people at present in Maharashtra as well as at all India level. He was the youngest president of All India Ophthalmic Society as far as I know. And he is chairman and president of many ophthalmic societies. His topic of discussion today is death on table. Very serious topic it is. Let us hear from him what he wants to say about death on table. Quresh Muscati, please.
Thank you.
Take over. Screen.
Thank you, Dr. Karandikar.
Yeah.
And I'll just share my slides with you. Is my slides visible?
Yeah.
Yes, sir. Make it slideshow, sir. Slideshow. Slideshow.
Slideshow. Corner.
Right next to 50.
Yeah. Okay. So this is a real life incident I'm sharing about many years back, about 20 years or so ago. I had a death in my nursing home. This patient came with multiple medical problems. He was an extremely obese patient. He had whatever disease you can think of, except cancer. He had everything: thyroid, diabetes, hypertension, heart disease, extreme obesity. I had to make special provisions in my theater for him to fit on the table, and collagen disorders. Patient was referred from Indore with bilateral corneal perforations because of his collagen disorder. And when I spoke to the surgeon who referred me, I said, what we can do is, under GA, we can put both eyes amniotic grafts to just save the eye, at least for another. Otherwise, he will become thicycle both eyes. So when the relatives came, I spent about 1 hour at least explaining why we are doing it under GA, because he's not a fit case. I cannot operate him twice, and the eyes are open eyes because of the perforations. I need to seal them. So if I give a local block, he might go in, the contents might come out, and that there is a huge risk. So my anesthetist sat with me in the chamber for about an hour, explaining to the relatives. There were about 4 or 5 relatives who came with the patient from Indore, and that we were planning to do these bilateral amniotic membrane grafts. Their relatives were briefed about the possibility of death on table as well. We didn't do any video recording. In hindsight, maybe that would be ideal, but we did spend a lot of time and document, as Dr. Jai said. We took special signatures from them. Separate letter was written. There is a possibility of death on the table, and signature of that was taken, that we explained in the language that we follow. All those things were done. It was not a routine consent form. The patient had successful surgery, came out of anesthesia, was actually wheeled out of the OT on trolley, and he waved to his relatives and said hello. Then all of a sudden he had a cardiac arrest while he was still on the trolley just outside my theater, being shifted to the room. We are in Mumbai, so we don't have large spaces. So it's a small nursing home, eight or 10 beds. And the anesthetist was standing there with the patient. So we moved the patient, immediately wheeled him back to the OT. All attempts to resuscitate were tried. I have a defib machine in my OT. We called the ambulance to shift him to the ICU. The ICU is in a large hospital just in the opposite building. But by the time the cardiologist came, it was about 10 minutes. He came with an cardiac ambulance from across the street. But when the cardiologist came, he was already declared dead by the cardiologist. The relatives were extremely understanding. They said, sir, just give us the body. We'll take the body back to Indore by train. But I refused. This is important to understand, that do not succumb to pressures from very cooperative relatives saying, कुछ नहीं होगा sir, आप सही कर दो, हम लेके जाएंगे, हमारी जवाबदारी. No. So I called in the police after making sure that my OT notes and the anesthetist notes were complete in every way. I cannot overstress what Jai said earlier. So we checked our notes. We called the police. In any case, the police took their own sweet time in coming. 75 minutes. This happened at about 12 noon. Police came after 1 o'clock in the afternoon. Then when they came, they said, why did we bother to call them? They were working at a very snail's pace. हमको क्यों बुलाया? Simply could have issued a death certificate, called a GP to issue a death certificate. Relatives don't mind. So I said, no, this is the law. We need to call you. You need to record this. So the police again requested me to get a friendly family physician to certify cause of death as heart attack and give the body to the relatives. They tried to explain, relatives want the body. No one wants to have any lafada. There is no case. Nobody wants to do anything. आप simply GP को बुला के heart attack लिखवा लो. I refused, and this is again something I want to stress, that this was the right thing to do, because you don't want legal trouble later. So then the cops requested for 5 witnesses. it's called a Panchnama. So you punch is for 5. So my staff were made the 5 punchers to be present while they talked to the relatives. So they took their own sweet time to chat with the relatives as well. The cops explained the further procedure. After the Panchnama, they would send the body to JJ Hospital, which is the state government hospital, where a post-mortem would be conducted because your doctor is not being cooperative. All this they're telling the relatives in my presence. Then after the post-mortem, the JJ doctors would issue a death certificate. This you will have to take to another government office, which will then issue a permission certificate for the body to be taken out of the state, because patient was from Madhya Pradesh. So since I had a clear conscience and the relatives so far were still cooperative, the cops were getting frustrated. They took over 2 hours in my nursing home to record just 2 pages of statements. There was nothing more, nothing extra to be recorded. Then they called a government hearse to take the body to JJ Hospital morgue. By this time, naturally, the relatives were getting tired. It was around 4 o'clock. Nobody had eaten food. So the relatives, the morgue, the peons, the class 4 employees at the morgue at JJ Hospital told them there were other bodies waiting in queue and things could get delayed by hours unless they gave the peon speed money. आप हमें पैसा दो, हम जल्दी जल्दी करवा लेंगे, otherwise it can take 1-2 दिन भी लग सकते, 2 hours also, 2 days also. I had actually sent my hospital manager with the patient relatives. Though I had sent my hospital manager, in spite of my hospital manager pleading with them not to give any money, they readily agreed and gave the peon all the money they had. The PM was finished, postmortem was finished in less than an hour after the money changed hands, and a certificate was issued. The morgue attendants themselves accompanied the body. Now, I had, in the meantime, when they had gone to JJ, I had rung up the undertaker. We have these Christian undertakers which embalm the body, because in the Christian community, they embalm, they keep for 3 days and then they bury. So I talked to them. They said, yes, once the postmortem is done, we will embalm the body, and then you can send it a day, 2 days later also back to Indore. So I had found out the costs and everything and kept ready the information. But the relatives never came back to me. Imagine what happened, how much of pull these class 4 employees have. The morgue attendants themselves accompanied the body and the relatives to the railway station. They completed whatever paperwork was to be required. They actually got the train going to Indore delayed by 10 minutes. If you are the governor of Maharashtra, you can't get the train to be delayed by 5 minutes also. But a class 4 employee in collusion with train officers can get the train delayed by 10 minutes. To allow them to put the body in the luggage compartment, he got the relative tickets for the second class compartment for the 18-hour trip home. So my manager came back saying that, sir, nothing is required. The patient has already, the relatives have taken the body back to Indore. So what are the lessons to be learned from this episode? First of all, put on the AC, air conditioner in your mind. So stay cool. Take the relatives into total confidence. If patient is bad risk, tell them about it before surgery. Don't reduce the risks. If it's a bad risk, possibility of death, please mention it, document it, take signatures, and take your time in the consent. In spite of this, if death occurs, don't leave the hospital under any circumstances. Be with the relatives and talk to them all the time. Don't run away from there. I'll give you a story, true story again. A very busy ophthalmologist in Mumbai had a death in his nursing home, and the surgery was done by the juniors. As soon as he was told of the death, he ran home. The owner of the hospital ran home and refused to come back. When the police came to the hospital, he told the juniors to deal with the police, and the police called him. And he said, no, I'm not coming. I will, my lawyer you can speak to. This is the wrong attitude, because there's nothing wrong. You have done nothing. But if you run away, it sort of makes everyone feel that you're guilty, that something wrong has occurred. So don't leave the hospital under any circumstances. Forgo your food, it doesn't matter. Be with the relatives, talk to them all the time, tell them we will try and help you at maximum. Second thing, understand the law and call in the cops. Insist on this and insist on the post-mortem. It will save you later on, because there were 4 relatives from Indore with me. There could be 5 relatives sitting in Jumri Talaya, 7 in New Zealand, and 6 in Timbuktu. They will all wake up and say, "Arey, hamara chacha, batija, whatever it is, mar gaya." And then they will ring you up, and then they will cause havoc because they were not present. You put out only those 4 relatives there. So you cannot put out all the relatives in the world. And every patient who dies develops relatives as soon as he dies. So understand the law, call in the cops, insist on this, and insist on the post-mortem. Second lesson, read page 13-14 of AIS CME series on legal aspects of ophthalmology. It's number 27. It's on the website as well. You can ask for a hard copy, extra hard copy from the AIS office. It's compiled by our own Dr. A. Deshpande of Aurangabad. So it clearly mentions that doctor cannot be arrested, though it is a cognizable offense under section 304A, according to Supreme Court ruling. So you don't have to run away. There is zero danger that you will be arrested. It cannot happen. A death on our hands, either with consent or without consent, if the surgery or treatment is done in good faith, earns us exemption under section 88 and 92 of IPC, Indian Penal Code. So this is very nicely written by Dr. Deshpande. It's part of the AIS series. It's a very thin booklet. Either download it or keep the hard copy with you. It can save your life because it tells you exactly what your rights are. Third lesson, do not try to bribe the cops. Do not submit to blackmail by relatives or pay them any money to hush up the matter. It is, you have done no wrong. Always in your mind, also it should be no wrong. I have done no wrong. Keep on saying it to yourself. I have done no wrong. You have tried your best. Nobody, no ophthalmologist wants to kill a patient. So don't try and hush up the matter. Talk extra than you would. At most, you may not charge your surgical and nursing home charges or refund them if you have charged them. Maximum, as a goodwill gesture, making it clear that this is not an admission of guilt. What I did was, I refunded to the patient these nursing home charges, the surgical fees, saying that you will need this if for the embalming and for taking the patient. I thought we would be sending the body by air. So I said, you may need this for your going back and whatever. So I refunded them that. They didn't even ask me for it. I just did it as a goodwill gesture, telling them what it can be used for. So nowhere is it an admission of guilt. So in conclusion, don't wash your hands off this situation. Don't run away from the place. You will never need to spend even a minute like this if you do not panic. May you never face such a situation. I thank you for your attention.
Thank you, Quresh. You have very nicely elaborated the situation which you have faced. My wishful thinking is no ophthalmologist should face such a problem. But as you have correctly pointed out, I was teacher in medical college. I was attached to the university also. Unfortunately, our curriculum of MBBS as well as post-graduation never include these subjects of law, finance, administration and other things. We have been pursuing that matter from Board of Studies of University since long. But so far, means so many 30 years or more have gone, but no action has been taken. Thank you so much. Let us pass on to the next. May I request Dr. Kothare?
Yes.
Yes.
I am glad to introduce Dr. Manoj Chandra Mathur. He is honorary treasurer AIOS. He is co-chairman Health Insurance and TPA Committee. He was past president and advisor Telangana Ophthalmic Society and Hyderabad Ophthalmologist Association. He was MC member AIOS twice. He was member of advisory board of IJO for 2020 to 2023. He was co-chairman for AIOS Ethics Committee. He was member of MedicoLegal Cell AIOS 2018. He was vice president of Vice President and Honorary General Secretary and Editor of erstwhile APOS. He is going to talk on AIOS Suraksha, indemnity insurance for ophthalmologists. Over to Dr. Mathur.
Thank you, sir, for that introduction. Is my screen visible?
No, sir. Start sharing, sir. Share screen.
Yeah, I am doing. I have clicked the button. Waiting for this. Is it now seen?
Yes, sir. It's coming.
So thank you, Vidarbha Ophthalmic Society.
Your slides are not visible, sir. Slides are not visible. Your screen is visible, slides are not there.
Yeah, I've just somehow
Yes,
the
sir.
internet
Yes,
is a little
yes, sir.
slow.
Yes, sir. Now it has come, sir.
Okay.
Yeah.
So
Slide show, sir. Slide show.
Nice.
I have done it.
Yeah, it's lagging behind.
Yeah. Okay.
No,
Now,
not yet.
yes, sir. Yes, sir. Now you can do it. Now you can do it, sir.
Has it come to?
Yes, sir. Yes, sir.
Yeah.
Yes.
So
Go ahead, sir.
my gratitude and thanks to Vidarbha Ophthalmological Society for giving me this opportunity. So after the talks about maintenance of record and how to tackle the situation in an unfortunate situation, let us now move on to know what we need to do to protect ourselves in case we face a legal tangle. So for that, we need to have a professional medical indemnity insurance. So what is this professional medical indemnity insurance? It is a professional indemnity. It's an insurance plan to financially safeguard medical practitioners against legal costs and claims for compensation by patients in case of a legal row. In today's litigious world, claims can be significant and can be detrimental to the financial security of the doctor. The doctor's expertise is protecting the health of the patients. The medical insurance expertise advises the doctors how to protect their professional interests. So why is it required? Because doctors are professionals who face the risk of a financial liability in the course of practicing their profession. The amount they can be sued for can be really exorbitant, as we have been seeing in the recent past. The doctors therefore require a special insurance so that they can protect themselves financially and legally when they can be sued for negligence. So what is the necessity? That means the statistics show that a staggering increase of 5.2 million medical negligence cases annually in India, about 110% increase in malpractice incidents, pointing to a critical need for action and protection. A whopping 400% surge in the legal battles, emphasizing the urgency to have a secure plan. And with the rise in negligence claims, it is critical to safeguard the rights of doctors and patients to keep the trust intact in healthcare. You must understand before we move further, there's something called a vicarious responsibility. Vicarious liability means a party is held responsible or not for its own negligence, but for the negligence of another. In this context of medical practice actions, hospitals can be held directly liable for their own negligence and can also be held vicariously liable for the negligent actions of an employee. So the hospital is legally liable for any malpractice committed by the physician, nurse, or other healthcare providers who are employed by the hospital. The scope of professional indemnity insurance is to provide cover for the extent of financial damage for the loss caused to the victim against unintentional errors and omissions by the doctor, insured qualified or non-qualified employees and staff. It also covers the cost of defending oneself in the court of law, that is the cost of decree. The plan covers for a period of 1 year. However, the policy does not cover criminal actions. This we need to understand. What is the compensation under the professional indemnity policy? The policy will pay the sum assured that has been set as a limit. The expense over and above the sum assured has to be borne by the doctor. That is understandable. The sum insured is referred to as the limit of indemnity. This limit is fixed per accident and per policy period. The indemnity insurance policy should be taken for doctors and hospitals with the staff separately. This is important. If you are a practicing ophthalmologist and if you are running a hospital, it is better to have your own personal indemnity policy apart from the indemnity policy for your hospital. And that should be renewed every year to meet the claims of Consumer Protection Act. Mind you, for indemnity insurance policies, there is nothing called a grace period. Before the expiry of the date, you need to renew the insurance, unlike the other endowment policies and other types of policies where a period of 1 month grace period is given. So indemnity insurance policies, what are the options available to you? You can either take your own independent professional indemnity policies by national general insurance companies or join some professional protection groups. If you take a professional indemnity policy by the national insurance companies, it only caters to your consumer claims. Indemnity is any act committed by the insured who shall be a registered medical practitioner giving rise to any legal liability. These are the terms and conditions. And the insured includes policy holding and his qualified assistants or employees named in the proposal. You need to read the lines in between and take a proper policy for yourself and for your institution. And policies can be available for individuals, hospitals, as well as diagnostic centers. The doctors, indemnity, national insurance companies, there is one note and caution. Short period policies are not permitted because you need to maintain a continuous policy all through till you practice. All claims have to be legally established. However, the company can opt for an out-of-court settlement, which should be accepted by the claimant. The jurisdiction can be all Indian courts. If you have formed a group of over 200 members, you can get discounts. But read the lines in between. It is not very uncommon. You will be saying, like, I am paying 16,000 rupees for a 1 crore policy. Somebody may say, oh, why are you paying 16,000? I'm paying only 8,000. There is something called riders in between the lines. There can be a co-pay rider. Co-pay 20% means that if you are sued for a lakh of rupees and if you are made liable to pay that 1 lakh rupees, you have to pay 20,000 from your policy, and only the insurance company pays 80%. That is 80,000 from the insurance indemnity policy. That is why the premium can be less. Then there is another thing that you need to know. Any one accident that is AOA limit of 25%, 33%, 50%, or 100% selected for any 1 year, that is pro indemnity. If you have taken a low grade premium for 1 crore of rupees and which says that the indemnity limit is 25%, that means for one incident you are okay for only 25 lakh claim and you are not covered for the whole 1 crore claim. So these are the nitty-gritties that you need to understand, all the basics about the professional indemnity policy before you decide what is best for you. So the best for you here, if you take an individual national insurance company policy by yourself, you are left to fend for yourself. You have no technical backup, and you have to fight your own case. And once the compensation is settled, you have to get it all. Once the case is filed in the court, then probably the insurance companies will appoint a lawyer or help you or come into the picture, and you have to fight the case on your own. But if you opt for a group insurance policy, before we go to the group insurance policy, we need to understand the most important clause to be understood. That is, as I told you earlier, the act has to be committed during the period of insurance commencing from retroactive date and continued thereafter without a break. What this means is, suppose you have taken a policy this year, and next year before the due date, if you have not renewed the policy, if you have renewed your policy even after a week of the expiry, the retroactive date changes to that date and not the present date. If something happens during this period of time, you are not covered by the indemnity insurance, because there is a break in the continuity. So from the date of commencement, from the retroactive date, the policy has to be maintained in continuation. That means there is no grace period, and you need to renew your indemnity policy before the date of renewal. So The group insurance, professional group policies are there. What you need to understand by this is here you have some backup, you have some cover. And we at AIOS during the last year, we had extensive deliberations and briefings from a company called CoverU, and we wanted to provide something substantial for the practitioners, like we did Guru Sangam for the teachers, we did OCAT for the students. We wanted to do something for the practitioners too. So first among the processes and the schemes that we have in our mind for the practitioners is to first provide a comprehensive indemnity policy to all the AIOS members. So this agency approached us and we had a briefing, and then we floated the scheme AIOS Suraksha, that is professional indemnity for ophthalmologists. So let us understand the company, what this company is about. This company, CoverU, is the only IRDAI broker serving the doctors' fraternity. There is exclusive medical association tie-ups of 75 plus associations. The MedicoLegal lawyer panel is pan-India. They have a panel of about 10,000 lawyers on their panel. They have a panel of 500 plus senior doctors who, in case of a contingency, can guide you properly. You're not left in the lurch the moment you get a notice. For 30 to 40% confidence is broken, you are shaken. But here, if you have a group indemnity policy, apart from a huge discount in the premium, you get all these facilities. And as of now, over 2 lakh doctors are enrolled with this insurance broker. Then it is serving about 20,000 plus hospitals have taken their policies through this broker. The Span India serving claims are there, 24/7 claim assistance, and there's a popular online buying and a dedicated team of employees. Before we move further, it is important to know that AIOS is not the policy holder. The insurance indemnity cover is between you and CoverU directly, and AIOS is only a facilitator. So these are all the list of medical association tie-ups that this company is having. Our AIOS is also proposing, we are providing this facility for a tie-up with CoverU so that it is beneficial for our members. What are the indemnity benefits, extra benefits that this, if you take insurance policy with this company, is that the coverage is for all sources of medical negligence notice, whether it is civil, whether it is even criminal negligence, they take cover, they give you cover. We will come to this later. For all the types of notices and litigations, they give you a cover. About 10,000 plus top tier medical legal lawyers are available, as I've already enumerated. You can select your own lawyer. If you think that you have a better lawyer, if you can suggest and you can prioritize your choice. The lawyer allocation, the moment you inform the company, a lawyer is allotted within 2 hours. And a panel of 500 plus senior doctors are always available for your guidance. And if there is a possibility of an out-of-court settlement, it is a possibility, and that is settled with a cashless claim settlement. And they provide a 3-year run-off cover. What is this run-off cover? Suppose at the end of your practice, you want to retire in practice with your premium cover. As I told you earlier, that the case can be filed anytime. So even after you give your final premium, you have a professional indemnity cover for the next 3 years. Suppose if something happens during the time when you are practicing, you have a cover. That means before you decide to retire or before you try to wind up your practice with your final premium, if any retroactive date case comes up for litigation, you get a cover. That is called the run-off cover. Then the breach of confidentiality. This is specifically for cases, for example, where the patient's details are revealed by the doctor that this so-and-so patient may have the IVF facility, for example. Like the patient's confidentiality, if there is a litigation on breach of confidentiality, you get a cover. If there is a loss of document or so, the company provides the cover. Dishonesty and criminal allegation. As I told you, for this action also, CoverU gives you a protection, but mind you, if the criminal negligence is proved in the court of law, naturally CoverU will not give the compensation if a criminal negligence is established. But till you fight the case, the company is behind you. The company will do its best to protect you. Then reappeal cost, if you want, if you lose a case and you want to appeal in a further court of law, the company again covers that cost also. And you can avail even better benefits of the continuity, like you join the cover your community, and they have read on a daily basis or a weekly basis, they have updates, some important information about various types of covers that you can, and the possibilities. They will be keeping you in the loop, and they will be keeping in touch with you through messages or emails. And over and above, like I can tell you in my personal experience, what I was paying the premium for the amount of cover that I was having, I am about supposed to pay only 1/3 of the premium if I port. The portability is also available. If I am having I'm presently, my personal example, I have a professional indemnity cover with New India Assurance Company. This cover policy can be ported to cover you. From the next year onwards, I may be paying a lesser premium as per this current policy, and my retroactive date will not change. The company excess is zero. That means, as I told you, there is no copay involved. There is no like any 1 year limits of 25, 33, 50%. The company compulsory excess that the doctor needs to pay is zero. And then you can join exclusive cover your community. So these are all the advantages that this company is offering you. We have gone into all the details of this after a detailed briefing, and the president gave the accent that yes, we can proceed for the benefit of practitioners. As a first step, this is our first rollout for the benefit of practitioners. And this is the premium chart for doctors' indemnity. As I told you earlier, you need a personal cover as per as also a hospital indemnity policy. These are the premium. For 50 lakhs cover, you need to pay only 3,249, and for 1 crore of rupees, you will pay only 6,500 approximately, and not 16,000 rupees if you take that policy individually. They cover also refractive surgeries. They cover also these things, the criminal negligence, as I told you earlier, but not the compensation if the criminal negligence is proved. They give you all type of covers, and then with this discounted policy, just because they have a permanent setup, they have they cover policies for over 2 lakh doctors all over the country from more than 50 to 75 associations, including different branches of IMA. And even if you want to have a cover for your hospital, for your technical staff, for your nursing staff, for your class 4 staff, these are the policy details. Whatever is adequate for you, you can take. And one caveat here is, if you are an oculoplastic surgeon, they have a rider. The policy is for minimum 1 crore. Instead of paying 6,500 rupees approximately, you need to pay around 11,500 rupees or 12,000 rupees. I have not included that in the slide. If you are an oculoplastic surgery, if you are doing cosmetic surgeries, even then you can opt for this cover you with an enhanced premium to cover for oculoplastic surgeries. And these are the panels. Since I'm addressing the Vidarbha Ophthalmological Association, just a slide the company has provided. These are the panel of senior doctors, lawyers in Maharashtra who can be deputed in case of an emergency for any of the AIOS members. So there is a seamless claim process. Number one, just an intimation to cover you, email, call, or website or association, they get activated. They can connect you with the lawyer within 2 hours. A complete discussion about the case is possible with the senior expert doctors empaneled with cover you. The lawyer representation is allocated to you. The compensation paid is directly to the patient, much less the tension and burden for you, and then a possible seamless closure of the case. So they have got a very good rating from various sources. The rating is 4.7 over 5, and then at cover you, every patient client, every doctor client is like a family. Your trust fuels their commitment to perform even better. So with this background of the company, AIOS has put forward a proposal to all the AIOS members, and over 200 members have already enrolled with Cover You. And I put forward this scheme for the members of Vidarbha Ophthalmological Association also. If you have any queries or these things, you can get in touch with me or to the cover. You can just express your interest, because we have not given the data to them, because they will unnecessarily flood you with the request. We are only emailing from AIOS headquarters to all the members, and in case you are interested, you just have to express your interest, and cover you will get in touch with you. You can have direct deliberations with them, and then you can get enrolled as an individual policy, but under the cover of the doctors of over 2 lakh doctors, where AIOS is only a facilitator. So thank you very much for this opportunity. My gratitude and thanks again to Vidarbha Ophthalmological Society for being with you all today. Thank you very much.
Thank you. Thank
If
you.
there are
Thank
any
you so
queries
much.
or this thing, I can try to.
Thank you. Thank you so much, Dr. Mathur. You have nicely elaborated the advantages, and we have got definite inclination now to join this particular indemnity insurance. Viral,
Yes, sir.
moderator, will you please take over and
Yes, sir. Sir, request to all the panelists to unmute themselves and start their video so we can give. Yeah. So, Dr. Goresh, sir, as we know that we have got also a Maharashtra Ophthalmic Society's professional indemnity going on, sir. So, what are the pros and cons as compared to this, sir?
We, after a couple of years of deliberations about during the COVID time, we did start with ICICI Lombard. Manoj, we started a professional indemnity along these lines. But it's not been tested in the sense that we don't know how good or bad it will be, because fortunately, unfortunately, none of our members have needed any help in the last 2 years. From those, about 600 of us joined this ICICI, but no one has needed the services of any lawyer so far. So we don't know how good or bad this will be. It's untested waters. So right at the time when we took it, I told people, don't give up whatever your professional indemnity, if you're already holding with someone else, don't give it up, because we don't know how this new person will be. They don't have a proven track record or nothing like that. What AIOS has done a tremendous amount of research into Cover You. I have gone into the depths of the Cover You, Manoj, myself. I have discussed it because I have a policy with my Association of Medical Consultants of Mumbai, which is an excellent policy. I have discussed it with the head honchos of my AMC, because I have that as a policy, and I have ICICI Lombard as an additional policy. So I've discussed this, and Manoj, it is almost mirroring the policy that the AMC has for its members. Of course, AMC policy is only for the Mumbai-based consultants. So I have no hesitation in saying that this is a well-researched policy by AIOS, and it will be a boon. Again, our ICICI, the amount of money that we are paying is about 1,500 rupees per year approximately. So it is a pittance. So you can forget about it. You don't have to port it. You don't have to do, just let it be as it stands. And I would say that take the Cover You policy, and MOS can also help the AIOS by spreading this, because AIOS, if it sends too many emails, there are enough people who complain. You're badgering us. You're trying. AIOS has no vested interest in this. As Manoj says, it is a facilitator. They have done research. I'm sure they've looked at several policies, and they've fine-tuned it by sitting with Cover You and fine-tuning it for our needs. So, I mean, hats off to them. And I think state societies should take a role and take over the headache from because it is for the good of our members. So take over the thing, and we can send emails sent by Maharashtra Ophthalmic or Vidarbha Ophthalmic to its members are more well received than emails sent by AIOS repeatedly, because people always suspect a vested interest when AIOS sends an email. It's unfortunate, but this is the tragedy. So I am convinced that it's an excellent policy, and I think I will be pushing at least MOS and all the VOS people are already here, Vidarbha Ophthalmic, to spread the message, and Manoj and others are always there to answer any queries. You don't have to go to cover you. Cover you once you've taken the policy, yes. But till then, if there are any queries regarding the policy, Manoj and his team are there for us. Thanks, Manoj.
Yes, sir. Yes,
Yeah,
sir.
I would like to add something to this. Basically, like the cover you people are also in the loop in the process of discussions with the MOS, to be honest. And there is a possibility of quoting the entire list of 450 odd members of MOS to this AIOS Suraksha. So they are interacting with the president and secretary through Dr. Parikshit Gokte. He got in touch with me. So if there is a potential of quoting our entire Maharashtra group to AIOS Suraksha. So that is a possibility. Talks are on the way. And it may be a possibility soon. And for the existing policies also, if you are personally interested, you can quote with this. Basically, and one more thing I would like to say, this portability for MOS group should not be a big hindrance, because even cover you gets the indemnity through ICICI Lombard only.
Okay.
IR is the only IRDAI broker, approved broker, as I told you in my presentation. And they
Manoj, the only issue is that do people have to be AIS members for this? Because MOS, all the MOS 450 members, there may be only about 175 AIS members for that.
Okay, so that's what with that exercise also we have just started yesterday. So we have sent emails to all the president, secretaries, and the managing committee members of the respective states to send us their updated list of state society members. So we have two things in mind. Number one, we will sort that list with the AIOS list from that particular state, and then we draw two lists. First list is AIOS members who are not state society members. That list will be furnished to the state society. They can pursue their members to become their society members. The second list drawn will be AIOS members of the state society who are yet to be enrolled as AIOS members. AIOS will proactively approach them to become members of AIOS, taking into confidence the state secretary and the president. We will give that list also. We will approach the members who are members of the state society who are yet to become AIOS members. We'll approach them to become AIOS members and take the benefits of AIOS. So this is the activity we have started just yesterday. So
yes, sir.
Hopefully in the next 3 months, last year we devoted our time for data sanitization. Now we have a 25,000 strong sanitized data of members with their emails and mobiles. So now we are starting this activity to increase. Last year we had a record number of 1,611 members taking AOS membership. So this time my aim is to set a target for 2,500 and above through this membership drive. Let us work all together. Let us hope for the best for the society.
Yes, sir. Thank you, sir. Great initiative by AIS, sir.
Yeah.
Dr. Adlakya, sir, you know, sir, he is with us. Sir, regarding this talk by Dr. Kuresh, sir, on death on table, sir, any differences you feel in a small place where we are practicing in a small district place or a small town like Nagpur or Varda? Any difference between approach to this death on table, any media or something like that?
Sir, sir, sometimes
Yes, sir, please.
if you declare a death in a hospital, the relatives, they are very much aggressive and they may take some bad actions against the doctors also. So is it necessary to inform police first, or should we ship the patient to the medical college or the civil hospital first and then they declare the death?
No.
Yeah, so I think you cannot generalize. It will depend on case to case and depends on your level of your security or insecurity that you feel. So if you feel that shifting the patient to a civil hospital or anything would be easier for you, yes, contact those people in the civil hospital. You should have friends in the civil hospital who will help you. Then they rush the patient there by ambulance without declaring the patient dead, and let civil hospital say that the patient is dead. That can be done.
Not dead.
But if as I did, it could be even in a smaller town, you could do this without the help of the civil hospital. It depends. So it's there is no right or wrong over here. It just depends on what is happening, the state of the relative's mind, whether you perceive them as hostile, non-hostile, and whatever you feel works best, you should do.
So my one
Yes,
question.
yes, sir.
Yeah.
Nitin, sir.
Yes. When you should inform the police?
After as soon as the patient dies, and your paperwork is complete.
So as you said that you should shift the hospital to the nearby hospital. So
Yeah.
after shifting the hospital and they have declared a date, then you should inform, or before
Yes.
shifting the patient?
No,
from
no,
the
no, no,
hospital?
no. Only after the
No.
patient passes away. Till you're
Okay.
making all efforts to resuscitate, even if the ECG is a flatline and you're shifting the patient to another hospital, you don't declare the patient dead. Once the patient is declared dead, then you call the police.
Okay. Okay. Thank you, sir.
And once you call the police, all your data and case sheets get seized by the police. So you have to just take 10-15 minutes to just go through your notes, and then till the time police arrives, you get it in order.
Yes, that is more important. Paperwork is
Yes.
more important.
Yes, sir. That the
Yes,
data
Take
gets.
a
Yes, sir.
photograph
Karanjikar, sir.
of the papers.
Can I ask a very basic question to Jai Bhopi? See, how long one should keep the medical record? Not in relation with the legal approach, but in general, for income tax purpose or for any other purpose. How long we should keep the record? Outdoor record as well as indoor record.
So NMC says that we should keep the records for at least minimum 3 years.
So that is for if someone has gone to the court.
Guidelines. NMC guidelines is there.
That is for
Sir is asking.
tax purpose.
Not.
Tax
For
purposes, it
tax
is 8
scrutiny,
years.
income tax purpose.
Sometimes scrutiny can happen. It is generally said that in 8 years record.
8
ban
years.
comes.
Yes. Another question again to Jai Bhopi. How do you do the numbering of outdoor cases and indoor cases so that it should facilitate to dig out the record as early as possible in a very short possible time?
So in the electronic medical records, that number is generated automatically.
So, but it will go on increasing, no? The number
will
will
go
go
on-
on increasing of outdoor cases, and then it will be difficult. So, is it that the year should be first, then the month
Yeah.
and the serial number, or some methodology is there, or there is no methodology?
Yes, sir. Sir, in EMR, sir, in EMR, if you type the name of the patient, then automatically the number
Right.
gets there. But in manual recording, Dr. Jai Bhopi will be answering.
So,
Yeah, in manual recording, you can do that numbering along with the year of the patient approached you. So it will be easy.
okay.
My one question to Dr. Mathur. If you have more than 2 indemnity policies, so whom to approach first? See, I have two. Yes, basically I am the MOS indemnity policy. My personal policy is different. Now I am thinking to join AIS policy also. So how should we proceed?
That, doctor, as Dr. Quresh said, like if you have any doubt about the new policy, this thing, probably for a year you may keep it. But here we are having, after knowing about the details of the company, so many more than 2 lakh doctors be having policies with them. I think it is wise for us to think that we are reasonably safe compared to us. So it's better to right away port your policy with this company, save on the premium cost, as well as have a it is only a one-off situation. How many of us do really anticipate a case against us? But unfortunately, if at all it happens, you have so much a big community behind you. That is the thought process. You have a sense of security if you are in a group through a policy rather than you are left to in the lurch trying to fend off for yourself. So if you have 2 policies, as of now, one thing is clear, like if you 2 policies, one should be for your personal this thing, and the second, if you are running a hospital and this thing, you can have a separate policy for the nursing home, for your eye center, because it comes under the jurisdiction of vicarious liability. So even if there is a visiting consultant in your hospital who is not an employee of your hospital, he is just coming to operate a case. If something goes wrong for that, even then your center is vicariously liable. So it is always better to have a hospital policy if you are running a hospital. Plus, it is better to have your own personal indemnity policy.
Okay, thank you, sir.
In case you are
Sir,
having two
Dr.
policies,
Mathur, sir. Dr. Mathur,
yeah. So let me complete. If you are having,
Yes,
say, two
Doctor.
policies, one
Yes.
for 50 lakhs, one for 1 crore, for example, suppose there is a claim for 1.25 crores at the end of it. So you need to inform both the policy people. For example, let one person fight the case in case the compensation is more than the limit of your policy can come into the play. But it all depends on the risk evaluation that you make about yourself. One good policy with a group is, I feel. Yes, sir.
Sir, yeah, there is a question from the audience. Sir, CoverU has got collecting premiums from 2 lakh doctors. But how many court cases are there going and how are they cooperating and what is their settlement ratio? Is there any data from CoverU on that? And how old is that company, CoverU?
Yeah, that technical data I can furnish if you just give me the number. I am not like right now orally I can't tell you, but their rating is good. They have shown the rating of 4.7, and that is their business. There are over 2 lakh doctors.
That's okay.
That is business. That is why, because they have 2 lakh doctors, the claim process will be very less, and they get so much of premium in crores, and they are able to manage at their level. And that cover is through the ICI Lombard. So probably they may be getting some incentive from that premium to cover their maintenance costs. Plus ICICI Lombard is taking care of the whole thing. So 2 lakh doctors are through CoverU with empanel with ICICI. That should be the thing that we need to understand. Yeah.
Okay. Yeah, Avijit Patil, sir. Dr. Avijit, sir.
My question to Dr. Mathur. I have already MOS indemnity policy of 1 crore.
Yeah.
And shall I take another from the same company, ICI Lombard, from the AIOS also?
No. The MOS, as I told earlier, the CoverU is in touch with the MOU, with the MOS team. So if the negotiations go on, if it is, there is a chance that all of you will be ported directly under AIOS Suraksha. Even otherwise, since the insurer is the same ICICI Lombard, this is definitely a separate group. But what is important now, AIOS, as I told you, is not a group policy. This thing, it is an individual policy. Even under MOS, your policy is individual, independent with the ICICI Lombard through MOS. MOS is only a facilitator.
Correct.
Like that. So whether it is through MOS or through AIOS Suraksha, I think MOS group or entire group should not be too much perturbed. If the portability is possible, if there is a chance that all the entire MOS group can be ported under AIOS Suraksha, well and good. Even otherwise, you are reasonably safe because the insurer is the same ICICI Lombard, and the rates are also the same. It is not that if you take it through AIOS Suraksha, you are paying something less. Even if you take as an independent policy, you are paying the same rate through ICICI Lombard. There is no.
Yes, sir. So there is a good chance that MOS group will get merged with inside the AIOS Suraksha scheme.
I don't have the updates. I have put the CoverU
There's a good chance.
In consultation with Dr. Parikshit Gopte. He got in touch and I put CoverU team to Parikshit. So Parikshit may have introduced them to the President and Secretary of MOS. But the negotiations may be on. I don't have that update about that.
Okay, sir. Okay, sir. Thank you. Dr. Vidya Madam, any inputs you want to put here? Yeah, please go.
Yeah. AIOS indemnity policy, I really like the way you have explained, and I'm looking forward to join this. Though I have my independent individual policies, but I would like to join that policy. Thank you, sir.
It probably gives a sense of security that you are one among from AIOS. But ultimately, your policy is individual between you and ICICI Lombard through CoverU. That should be the best definition that we can give.
Dr. Khandewale, sir. Ajay, sir.
Yes, I want to ask Kuresh sir one question. If any untoward or unfortunate incident happens in OT in absence of anesthetist, so if you are not called for uncomplicated or normal patients and unfortunately patient dies on table, so is surgeon is liable for litigation, or in other words, anesthetists are mandatory in each and every case.
Even through AIOS guidelines, in nowhere does the word mandatory come. So it is recommended by AIOS for high risk patients to have an anesthetist, but it is not mandatory anywhere. So even if you're doing it in a small place without anesthetist, there is no legally you're not bound. But what I would suggest, if an untoward incident occurs, if you can quietly, now that we have mobile phones, if you can quietly call an anesthetist before coming out of the OT, to come into the OT. So from wherever he is, say there's an emergency, please come. Let him come into the OT and then let him help you to whatever extent is possible. And then
in presence of him, we should declare. In presence of him, we should declare the death or this. In presence of anesthetist.
Better. It's better. It's better. Yeah. I'll give you an example. I'll give you an example. There was a patient taken for sac syringing in the OT. Unfortunately, instead of doing it in the ward for whatever reason, patient was taken in the OT for sac syringing, and patient had a vasovagal during the sac syringing and died. And obviously there was no anesthetist. The problem is there was no nurse or anybody. The doctor took the patient alone inside in the theater, and then legally the case went against the doctor that any patient you take into the OT, you must have sufficient help. It is not anesthetist, but at least you have sufficient. You are all alone by yourself. That is wrong. So there is safety in numbers. If you can get an anesthetist to quietly come into theater, it's so much better.
One more recommendation in very high risk cases, as Dr. Kuresh explained in his case, this thing, some institutions, they prefer to have a standby ambulance. So that also goes a long way in safeguarding yourself, just in case if it's a very high risk case, cardiac case, and you are trying to do surgery for that patient, a standby ambulance documentation may be a wise idea.
For smaller hospitals, it is really very difficult. It is also in the NABH guidelines and everything. But to keep an ambulance, or even in smaller places to have an anesthetist, in smaller places, it is very difficult to get the anesthetist. And when he knows the things, he is called for resuscitation. He may avoid that responsibility also. He won't like to get involved along with the ophthalmologist.
Definitely. At least to make a MOU with them.
Reality.
That is the thing. The role of anesthetist in an OT, in ophthalmic OT, is not to give a block, but to be a standby.
Yes, that's great. We always keep in Nagpur standby anesthetist. I remember one instance in an eye camp where there was a tendency to give block outside on the bench and then send the patient inside. Once we started giving block, the needle inside and the patient went up. So this also happened, but because of that, it was a camp and every politician was involved in that. Nothing happened afterwards. I also don't know what happened afterwards with the patient or the thing, but anything can happen sometimes, and one has to face the music.
Yes.
Dr. Regarding ambulance issue, once I had incidents and I had to shift to patient immediately to ambulance, and ambulance told me that he will reach in 15 minutes. Instead of that, in OT dress, I took patient in my car and shifted to physician.
वो तो करना ही पड़ता है. वो तो timely decisions are more important sometimes.
And patient, the life was saved and patient improved and came out of the ICU also.
You are lucky. You are lucky.
Right.
Dr. Jay, is it mandatory to have a patient signature on the referral letter?
Yeah. It is better if the patient gives the signature, because to prevent the future complications, that is mandatory.
One more question to Dr. Jay. Is it necessary to take this patient's signature on discharge card and bill? Final hospital bill.
Discharge card,
Because in
there is no
NABH
Discharge card, there
NABH
is no role.
guidelines, it is
There is no role of taking signature of patient on discharge card. You only have to take that you have delivered it. You have to take that the patient has been given discharge card and get it signed in your register.
Received
Discharge card issued. Yes.
Received.
NABH
Yes.
guidelines that you have to sign by the patient on the copy discharge card also.
yes, sir.
Discharge card
NABH,
issued.
as per the NABH
Right.
guidelines, they have said.
NABH
the
guidelines.
copy.
Ideally, I take a signature on the copy of the discharge card as well. It may
Copy of
not
the
be discharge card, but some discharge paper. Somewhere you need to take a copy because you're proving that the patient was alive and well. He could go down outside your nursing home and die. But he left your nursing home. He was fit, fine enough to sign that document himself and is gone. So I think it is quite useful.
Okay.
Okay.
Dr. Ade sir, Jayant sir, Dr. Jayant Ade sir. Any inputs you want to?
Hello.
Yes sir. Go ahead.
I'm not getting proper sound. There is some disturbance.
Okay. Sir, Dr. Karandikar sir, Dr. Kochade sir, we are well past our time. So any further discussion we want, or shall we wind up, sir?
I think it's time to wind up.
Sometimes,
Yes, please.
sometimes police are reluctant to note the complaint for death.
FIR.
FIR. They are very reluctant. So in that case, we can give email and hard copy of our information.
No, what you have to do is if on phone call they refuse to come, you send a man with a letter saying that this is we have had a death on table, or you had a death in my nursing home. We request you to come for the panchnama or to take over the proceedings, and take a signature of the station officer that you have delivered that letter to them. They have to come. It is by law they have to come. So let them sign. If they sign that they have received your letter and still don't come, then they are breaching the law.
Okay.
Once they know that you know the law, they will come.
Correct. Viral, ask
Yes,
the
sir.
secretary. Ask the secretary.
Yes, sir. Shirish sir, Dr. Shriram Lavade. Yeah. Dr. Lavade, please propose a vote of thanks. Formal. Unmute yourself. Yeah. And before Dr. Shriram gives a vote of thanks, I request Mr. Rahul Jain to take a screenshot of our webinar with all the participants. Request to all the participants to start their videos and audio so we are visible in the screenshot.
Viral, you didn't tell us this. I would have worn a tie and suit.
Sir, we will Photoshop you, sir.
Otherwise also you are pretty smart.
Yes, sir. Yeah, thank you. Done.
Thank you.
Done.
Yeah, please unmute yourself.
Lavade.
Share. Yeah.
Am I audible, sir?
Yes, yes.
Yeah.
Thank you, Viral, sir. On the behalf of Vidarbha Ophthalmic Society, I would like to take this opportunity to thank our eminent speakers, Dr. Quresh Maskati, sir, from Mumbai, who have given a very wonderful presentation on table death, what next. Second speaker, Dr. Manoj Mathur, sir, who had given a nice presentation on VOS Suraksha and indemnity insurance for ophthalmologists. Our third eminent speaker, who is our own VOS faculty, Dr. Jay Bhopi, sir, from Pusat. We have focused mainly on medical record keeping for ophthalmologists. All the three topics are really very important for each and every ophthalmologist, which is very important in our day-to-day ophthalmic practice, and that will really help all the VOS members in our routine practice. Secondly, I would like to thank our chairperson, respected Dr. Sriram Karandikar, sir, and Dr. Satish Kothade, sir. We have really given time for our late night VOS webinar. And our all-rounder moderator, Dr. Viral Shah, sir. Thirdly, I would like to thank all the expert panelists, Dr. Vinod Arlake, sir, Dr. Vidya Dashputra, madam, Dr. Nitin Upadhyay, sir, Dr. Ajay Khandewale, sir, Dr. Abhit Patil, sir, and Dr. Jay Ade, sir. Thirdly, I would like to thank all the viewers who have joined for this late night webinar out of his their precious time, and we have made this seminar, this webinar, successful one. And last but not the least, I would like to thank that Endor Pharmaceuticals and for giving us providing us technical support to this late night VOS webinar. Thank you, everyone. Thank you all. Good night.
Thank you.
Thank you, everyone. Good night.
Good night.
Sir.
Thank you.
Thank you. Good night, sir.
Right, everyone.
Thank you, everyone.
Mathur sir. हॅलो
काय शिरीष डिफिकल्टी चालू का अजून?
नाही नाही ठीक आहे उद्या तो
आता नेहमी करणार का हे रात्रीचे म्हटलं रात्रीचं नेहमी करणार का वेबिनार आता?
नाही, ओनली those topics which will give you sleepless nights. Only that.
Nightmares. Nightmares for viewers.
Today's topics were really offbeat.
Yes.
Night discussion. Thank you all.
Thank you.
Okay,
Thank
good
you, sir.
night,
Thank you.
everybody.
Good night, everyone.
Good night,
Sir,
sir.
I think that combine photo shoot, that combine pics. Mr. Jain was taking that combined pics of all the.
He is taken
screens.
probably.
Yes.
Taken, yes.
I think he
Yes,
had taken. Okay.
Yes. Okay. Good
Thank
night.
you, sir. Thank you. Good night, sir. Thank you.
Good night.